Hi everyone, I am Ahmed Mohammed, lecturer of cardiology at Ain Shams University, and today I will be explaining the concept of confidence interval, how to interpret the confidence interval, and the concept of clinical significance. All are needed to understand the results of clinical trials. Okay, first, let's suppose that I have a drug X, and this drug X is assumed in animal studies and phase 1 and 2 studies to be lowering the arterial blood pressure. So how to verify this on real population patients and when to use this drug X or not? First, I have to conduct a clinical trial. This big shape represents the whole population of hypertensive patients worldwide. But I can't try the drug on all of those patients. So I will take a sample, a representative sample. Okay, let's say it contains 200 patients. Contains 200 patients, and I will randomize them to either receive the drug X, the new drug, or the standard of care. And this standard of care can be either no treatment, so I'll be giving those patients placebo, which is an empty tablet with no drug, or the standard of treatment could be an older drug or another drug, so I will be giving the original drug. After a period of treatment, I measure the arterial blood pressure, the mean blood pressure here and there, and using the unpaired t-test, I got a mean difference of minus 30 millimeter mercury. So first, is this difference real? And if this difference is real, will I start to prescribe drug X to the hypertensive population or not? And that's why I get the concept of the confidence interval. It's so important in those. The confidence interval is used because the outcome that I measured in this experiment, which is the mean difference of minus 30, does not represent the difference in the whole population. It's the result in my sample, which could be a little different from the population. And that's why I need the confidence interval, as the results reflected in the sample could be used as an inference to the results in the whole population. So what I will do is construct a range of values around this point estimate, a range of values around this estimate. Some are less and some are more than those estimates. And in this range of values, which is the confidence interval, it will reflect the real result or the real outcome in the population. And what else does the confidence interval does? Apart from representation of the outcome, it also is a measurement of precision. The narrower your confidence interval is, the more precise your results. To say it in simple words, the higher number of subjects you include, the narrower your confidence interval will get, and the results will be much closer to the real population. Okay? And this is how to interpret the confidence interval in simple words. If I give you a range and told you that from X to Y, this is the confidence interval of my estimate, which means I am 95% confident that a true estimate lies within this interval. Or in other words, if I repeat this experiment 100 times, in 95 of them, the results will be within this interval. Okay, let's explain this by a simple example. I woke up late for my plane, and I need to reach the airport in 60 minutes or else I will miss my plane. So I have 4 means of transport. But I don't know exactly when those transports will be delivered me on time. So I have a time range for each of them. Each of them will deliver me or will get me to the airport in this range. What options do I have? I have the bus. The bus will get me there in 70 to 90 minutes. The underground in 45 to 50 minutes. The motorcycle in 25 to 30 minutes. And the taxi in 50 to 70 minutes. But remember, I have only 60 minutes. And if I miss anything delivered will get me there beyond 60 minutes, I'll be missing my plane. So I will plot those in a nice curve, and this curve is called the force plot. My neutral line or my neutral point will be the 60 minutes. Beyond those 60 minutes, I'll be late and I will miss my plane, and less than those 60 minutes, I'll be on time. And then I will plot the 4 means of transport along this curve. First, in the bus will be getting me there in 70 to 90 minutes. So definitely I'll be late and I'll miss my plane. The underground in 45 to 50 minutes, as we explained, and it can get me there on time. The motorcycle in 25 to 30 minutes. Wow, it's fast. But there is something wrong with the motorcycle. I'll tell you later. The taxi, well, I'm not sure. it can get me there on time, can make me miss my plane. So in case of the taxi, I'm not sure whether it is useful or not. And this is how we explain the confidence interval. This is how we use this on our drugs. And how confident I am in those results? 95%. Okay, let's say and first what I will do, like I told you, I will take the underground. There is something wrong with the motorcycle, and we will discuss this later. So if we plot those as 4 drugs, and each of them was supposed to lower the stroke risk in patients with atherosclerosis. First, I have the bus, the drug A, and the drug A mostly will cause more strokes. There is evidence of harm, so I will not be using it. Drug B lowers the risk of stroke, as well as drug C, so I may be using one of those. But what about drug D? What about the taxi? It could be useful, and it could be harmful, and it could be having no difference. It could be not effective, and in either way, I will not use it. So what if the confidence interval hits the neutral point? And the previous example, the neutral point was 60 minutes, but the neutral point is either 1 in the relative estimates, like odds or the risk ratio, as the numerator would be equal to the denominator, and in absolute risk, as it is a difference, the neutral line will be 0. What about those? I here simplified this. This is the neutral line. I'm using here the risk ratio. So the D, or the drug D, could be lowering the strokes or could be increasing the risk of strokes. So how can I interpret this? It is either interpreted as evidence of absence, which means I know that this drug doesn't work and I will not be prescribing it, or there is absence of evidence, which here I'm not sure whether this drug will benefit the patient or not, and I don't know whether to prescribe it or not. And this is where, the concept of, I need more studies. So how can I decide whether is it evidence of absence or absence of evidence? Okay, I will have to check the number of events in the control group. And this is, as a thumbs rule, if the event rate of the control group is more than 300, it is evidence of absence, which means this drug doesn't affect the outcome. And another thing that I have to check is the number of subjects in the experiment. Why? Because if I have 100,000 patients in my clinical trial and there is no difference between the drug and the placebo, it means one of two things. Either there's really no difference, or it is a too small difference that I cannot measure using 100,000 subjects, which is not a clinically significant difference to be of value. So it's it's equivalent to having no difference. Okay, let's check this example. This was a meta-analysis of 2 trials in Cochrane. It was about the aspirin versus placebo in the ischemic stroke, and the outcome was the intracranial hemorrhage. If I check here, the confidence interval has 2 ends, one end below 1 and one end above 1. So does aspirin increase it or not? Let us check first the event rate in the control group. It's 167. It's a little less than 300. However, look at the number of subjects. It's 41,000. So a difference that I cannot measure with 41,000 subjects, it's not that significant or not of value. So mostly aspirin doesn't increase the risk of stroke the risk of intracranial hemorrhage in patients with ischemic stroke. And this brings us to another concept. So does anything that is statistically significant, like drug B or C on the previous example, remember this one? The drug B or C and C are both significantly causing less strokes, so they are beneficial. Will I use them both or not? It depends on another things. First, statistical significance has to be translated to something that I call a number needed to treat, and I will explain that later. And this number needed to treat needs to be explained in the light of applicability. And applicability has many issues, like the cost of the intervention or the drug, the cost of the surgery, the availability of personnel that can perform this intervention or this surgery, or the availability of the drug, the acceptability, the presence of safety and adverse outcomes. Okay, let's take an example. First, look at this. I have a group with aspirin and another group with placebo, and after an ischemic stroke, I'm giving them aspirin to check if aspirin prevents the recurrence of ischemic stroke. The risk in the aspirin group is 0.1 or 10%, and in placebo is 0.3. How to calculate the number needed to treat? The number needed to treat is 1 divided by the absolute risk reduction. And how do I define the number needed to treat? It is the number of patients or subjects that I need to give the intervention, like giving statins, giving aspirin, or doing a certain surgery to gain one favorable outcome. The favorable outcome could be prevention of stroke, like in this example, or prevention of myocardial infarction in case of statins, or prevention of fractures in case of bisphosphonates. So in here, the absolute risk reduction will be 20% or 0.2. And when inverting it, it's 1 divided by 0.2 equals 5. So I need to treat 5 patients with aspirin for the same duration of the trial, for example, 1 year, to prevent 1 stroke among those patients. And this is very good. So this is the first part of clinical significance, translating the statistical significance into clinical significance. So another thing about the number needed to treat, it's important to interpret in all clinical trials as the relative risk or the relative risk reduction can be very misleading. Check this example. I have an event, or say the stroke, in drug A and drug B. The drug A have an 1,000 of 10,000 strokes, and the placebo has 2,000. So the risk here is 0.1 and there is 0.2. However, drug B have 10 out of 10,000 strokes. So if you calculate the relative risk for both, it's very misleading. It's 50%. It's the same in both. However, if you calculate the absolute risk, just check. The number needed to treat is 10 in the drug A, and for drug B, it's 10,000. So it's obviously which one you are going to prescribe. What about the other items that I told you about? The other items are very important because the number needed to treat cannot be interpreted without them, and I'll be elaborating by an example. Even if the number needed to treat is well, what if the drug is or the intervention is very expensive? What if it is not available in my country? What if it is socially not acceptable? What if it is not safe? The adverse outcomes are not acceptable. All of those will cause the drug to be rejected or the intervention to be rejected. So it's not only about statistics, but it's only about the applicability. And this goes very well with the motorcycle. Remember this one? It was effective. It lowers the strokes. It will get me to the airport in time. However, first, I don't know how to ride a motorcycle, and I don't have a license for this. I will get apprehended, and the motorcycle cannot enter the airport. So I will end up not using it because it's not applicable. It may be clinically significant, statistically significant, but it is not clinically significant. It is not applicable to use. So another application. Let's say I have given a trial for the aminocaproic acid in trauma patients, and I found it to reduce mortality with a number needed to treat of 60. The number may seem large, however, it's not that big because I'm speaking about mortality, which is a very, very important outcome. And second, the Capron is a very safe drug. It's very cheap, and it's available, and with no side effects, with no adverse outcomes. So in any patients coming with a polytrauma, I'll be prescribing Capron on admission. So let's get back to the first example about the mean difference. When I say the mean difference is -30, I need to complement this by a confidence interval. And here the confidence interval is within 26 to 33 millimeter mercury, which means that the real outcome of blood pressure reduction in this population will be 26 to 33, which is, for me as a cardiologist, this is a very significant reduction of the blood pressure, and I think I will be prescribing this drug. And that was all. Thank you.